So today we'll be covering briefly about what are the commonly used opioids in palliative care setting. You might have seen different opioids in some of the settings in ICUs, or if you are working in a theater setting, you might have seen some of the opioids being used. So today we'll be focusing mostly on opioids that is used in palliative care setting, and a little bit about the mechanism of action. It's important for you to know how it acts so that you can tell the patients and monitor them for side effects, and you can tell them why. They will ask you a lot of questions, why this is not effective or why am I having this. So you need to understand a little bit of mechanism of action and how to use, practically how to use these opioids in your setting, and some of the adverse effects, and what are the price, sorry the for the spelling that what is the cost of opioids in an Indian setting mostly. So I hope you are all familiar with this ladder, right? Have you seen this ladder before? In the last session? I need some response, yes or no, or thumbs or something. Have you seen this ladder? Yes. So the first step, you have already heard the first and the second step, right? You've heard about the NSAIDs, you might have heard about adjuvants, you might have heard a little bit about tramadol and tapentadol in step 2. So today we are going to deal with the third step. What is in third step? Third step has strong opioids, right? So what are the strong opioids that you have seen in your hospital or in your institution, wherever you are working? Can you type it in the chat? What all opioids you have seen, you have used? Either you can unmute or you can type it in the chat, I will read. And people outside India, you can also contribute what opioids you have in your setting. Yeah. So Aditi is telling tramadol, Evangeline is telling morphine, pethidine, fentanyl. So one person have seen morphine, some person have seen fentanyl. Yeah, some of you have seen morphine or used morphine, right? Anything else? Any other opioid you have seen? Have you been seeing this in for a pain management purpose, or in a ICU, or in a theater, or for surgical needs, or for cancer pain management? Yeah, pain management. Yeah, oxycodone. So I guess you are not from India, right? Yeah. So you have seen in pain management. So we'll thank you for the chat, and please keep up this interaction. Otherwise, we can't learn. To be very boring, just me talking till the end. Fentanyl patch for pain management. Thank you so much. So we'll start with a story which we deal with in a palliative care setting almost daily basis. This is a common scenario that we see almost every day. That is a 56-year-old man with the carcinoma larynx. So he came to us with pain around the neck, which he told, which is a sharp shooting pain. There is no radiation to any other sites, and he scored the pain on 10 out of 10 in numerical rating scale. And this is very commonly told by our patients that because of severe pain, I was unable to sleep for last 2 weeks. So we'll see how to manage this patient. So I'm not asking you how you're going to manage, because probably some of you have seen, only a few of you have seen morphine and for pain management. So I'll just talk about what we do in a palliative care setting, or what can be done. So this is something called intravenous morphine trial. Some people might have heard about it, or it may be very new practice that you might be hearing this for the first time. So this is a very good procedure for controlling acute pain, or to understand what dose of opioid the patient needs, what up to what dose that patient needs for better pain control. And this is how it is being done. This is you in your setting, you will have injection morphine available. It will be either 10 milligram ampule, that is 1 ml is equal to 10 milligram, or you will be having 15 milligram ampule. That is the two preparations available in India. Maybe outside India, there are more strength available. So dilute it so that each ml is equal to 1 mg or 1.5 mg. Okay, clear till then? So we are taking morphine in the ampule, we are diluting so that each ml will be either 1 mg or 1.5 mg. And you start your morphine trial by giving one dose, that is 1.5. This is in our setting, we get 15 milligram ampule. So when you dilute it, each ml is equal to 1.5 milligram of morphine. So you inject this morphine 1.5 milligram every 10 minutes. It is not single dose. You inject every 10 minutes. Is there anything that you give before giving morphine in your setting? Just before giving morphine, is there any drug that you want to give to avoid some side effects? Any opioid. Can be tramadol, it can be morphine, or maybe fentanyl, something that you want to give before giving any opioid. I'll wait for the chart to come. Yeah, some antiemetic. Sister Sunita is telling injection emised. So any antiemetic that you need to give before giving an opioid, because opioid has a high emetic potential. People can vomit if you don't give antiemetic before giving an injection of opioid or any oral preparation of opioid. So you have to give injection metoclopramide. That is the drug of choice for morphine-induced nausea and vomiting. So once this patient, this male patient is coming to your, thank you, Aditi. She's written injection perineum, very correct. Injection emisode is also given in many settings. That is not wrong, not at all wrong answer, but the better antiemetic for morphine will be perineum. That's all. Injection emisode is not a wrong answer. So what will you do? The patient is crying in pain, 10 out of 10 pain. You can put in a scalp vein or cannula, whichever is used in your setting. It can be done subcutaneous also. Here I am mentioning about IV morphine trial, where you put the cannula, you tell the patient that I am going to give an injection to relieve your pain. Start with an antiemetic. Give 10 milligram of metoclopramide, that is perinom, as an antiemetic. And then give 1.5 morphine every 10 minutes. So there is a question from Liana asking whether it is subcutaneous or intramuscular. The injection is never intramuscular. It is always either subcutaneous or intravenous. If most of the patients coming to our setting, we may not have access to the IV line. They'll be undergoing chemotherapy for quite a long time. They'll be tired. They may not have eaten or slept or had some fluids in the last few weeks. So usually the IV access is very difficult to get. So we don't want multiple pricks. That time we give subcutaneous, or you can give intravenous, not intramuscular. So either subcutaneous or intravenous. So how long will you continue giving this this 1.5 milligram morphine? We stop when the patient is telling that they have satisfactory pain relief, that my pain is okay now. I am pain free, or my pain is much, much lesser. It's a very, very low score. Or the patient is telling you that I'm feeling sleepy. Whichever happens first. Sometimes they say good pain relief, they will not be sleepy. But sometimes some patients say that I am starting to feel sleepy. That is, drowsiness starts to set in. That moment you have to stop the trial. Is it very clear till now? You have to understand this very, very clearly. This is the most important thing that you have to learn in pain management. When someone is coming to you with severe pain, this is what you can do in your setting. You'll see wonders. The patient will start smiling, talking, and they might have not had sleep for last few days or weeks, and they'll be so happy. Generally, the result is like miraculous. So you have to understand how it is being done. Is it clear? Can we go ahead? All said, any doubts in this? Yeah. So whichever happens first, we have to stop. This is how you should document because you are giving a morphine trial, right? You have to document it very, very clearly. Especially when you use any opioids or any medications, I know that nurses document really, really well than doctors, right? You write a lot of things, you document things really well. This is how you should document a morphine trial. Here they have written the time. So the morphine trial was started at 10 o'clock in the morning. At that time, you can see the pain score was 10 and the drowsiness was 0 or no drowsiness and 1.5 milligram was given. And then you keep your watch. After 10 minutes, you ask the patient what is the pain score now. How much the patient is telling? 7, right? That after 10 minutes, the 10 became 7. There is no drowsiness. So we gave one more dose of morphine. Again, after 10 minutes, you are asking, how is your pain? He's telling 4 out of 10. So that is not complete and he is not at all sleepy. You can give one more dose. That is 1.5 milligram of morphine. Then you ask after 10 minutes, the patient told you that pain score is 1 out of 10. That means good pain relief, right? You can't reach till 0. 1 is a very reasonably good pain score. So, and again, the patient is not at all drowsy. That is where we stop morphine trial. So, how much morphine has gone into him now? Can someone tell in the chat? Total dose of morphine which was required for Mr. X for his good pain relief. So total of 4.5 milligram. Thank you, Aditi, Vinita, and Liana. Thank you, Anupam. So I'll start calling names if someone is not responding. Okay. I don't want you to sleep in the afternoon session, and this is very, very important in pain management. So now the patient is pain-free. Now you have to send this patient home, right? He's not going to stay with you forever. Now you have to send this patient back home. That time we have to convert this into oral preparation. So how will you convert? Usually, how will you convert from IV to oral? You multiply by 3, right? You multiply by 3 so that to compensate for the first pass metabolism, right? So in the morphine, it is slightly different. You don't multiply it by 3 because you are giving titrated doses. That means you are not giving a single injection of 4.5 milligram. You are giving it at every 10 minutes like a titrated dose. So you have to give the same dose orally every 4 hours. So for this patient, I will give 5 milligram morphine every 4 hours. I will not multiply it by 3 or divide it by 2, nothing. Just convert this into dose, the 4.5 milligram. So we don't get 4.5 milligram. 5 is the easiest, nearest dose that is available. So you can give 5 milligram every 4 hours. You have to make it very clear. This will be asked for your exams or your assignments. So it has to be very, very clear how you calculate or how you convert from IV to oral. Because I'm not giving 4.5 milligram bottles, I'm giving titrated doses. I will give the same dose can be converted to oral per dose. So this will be the prescription for this particular patient. I will give morphine by the clock, by the mouth. That is 5 milligram. We don't get 5 milligram tablets. In our setting, we get the least possible doses, 10 milligram. So we tell the patient to break it into half. So half tablet, as soon as he wakes up, 10 a.m., 2 p.m., 6 p.m. And have you noticed bedtime, there is double dose. Because the one dose will come at 2 a.m. If you give it 4:30, the patient will have to get up in the middle of night at 2 o'clock and then take half tablet. Already he is not sleeping. So what we do? We do give double dose at bedtime. So make it very, very clear. All the doses are 5 milligram. The night dose will be double dose. So if the patient is on 10 milligram morphine, all the doses will be 10 milligram, but the night dose will be 20 milligram. Night dose will always be double dose, and morphine has to be given every 4 hours. And in the end, you can see one thing called SOS. So whenever the patient has pain, they can take an extra dose. Whenever. Suppose I have taken morphine at 10 o'clock, 5 milligram morphine I have taken. I have good pain relief, but suddenly at 12 o'clock, I am having severe pain. But my next due is only at 2 o'clock. 2 hours I have to reach 2 o'clock, right? Should I be in pain? For other medications like tramadol or paracetamol, you can't give like this, right? You can't tell them whenever you have pain, please take tablet. But in case of morphine, you can tell them to take one extra dose whenever they have pain. Just make sure that there is a gap of 1 hour between all the doses. If I have pain, but still I cannot skip the 2 p.m. dose. Even if I take at 12 o'clock, I have to take the 2 p.m. dose. The 12 o'clock dose is an extra dose. It is not the regular dose. So you have to give regular doses at 4th hourly period. Plus in between, whenever the patient has pain, you can always give an extra dose. You should not skip the regular dose, even if you are taking extra dose. Is that very clear? Any doubts till now? Okay. So this is very important because patient will ask you, ma'am, so another thing, suppose I am having pain at 1:30. 10 o'clock I took 5 milligram. I have pain at 1:30. I can take the extra dose, but it is very close to the 2 p.m. dose. I may not need to take the 2 p.m. dose because morphine will take around 40 minutes to start acting. So if it is less than 1 hour close, you can skip the regular dose. Otherwise, you have to take the proper dose. So suppose you are in a setting where you are in a home visit where you don't have IV morphine with you and the patient is in severe pain. You don't have injection morphine. What we can do is called oral morphine trial. If the patient is very new to opioid, you can give 5 milligram every hour. You can tell them, take 5 milligram now, still ask for the pain score after 1 hour. Now, what is your pain score? They may tell 7 out of 10. Give one more 5 milligram. Wait for another hour till you get satisfactory pain relief or the patient becomes drowsy. That is called oral morphine trial. If the patient is already on tramadol, you can start with 10 milligram, or if the patient is very new to opioid, it is better to start with 5 milligram. So this is how we do oral morphine trial. I hope that is clear till now. These are very basic things. You have to be very thorough about this calculation. So we will take scenarios one by one. Okay. This another story. So, the same patient, when we gave morphine trial, he had good pain relief with 4.5 milligram of morphine. Now he's taking 5 milligram 4th hourly SOS. He's having good pain relief for 2 weeks. The same patient, you have given oral morphine, he has good pain relief for 2 weeks. But while he came for the review, he's telling you that I need 4 extra doses per day for the last 4 days. I'm taking regular dose every 4 hourly, plus I'm taking 4 extra doses every day for the last 4 days. What can be done now? There can be right or wrong answers, but just think, what should we do? How will you control his pain? Increase the dose. I got one response that we have to increase the morphine dose. Anything else? Increase the frequency. I did not understand what Richa has mentioned. Weak clock method, I'm not sure what I mean by that. Increase the frequency. Again. Yeah. Okay, yeah, we follow the clock method. Means you give only fourth hourly. I guess you are trying to tell that you will not increase the frequency, but you will just follow the round the clock method. Increase the dose. So, yeah. So we'll see what shall we do. When there is two or more than two PRN or SOS doses taken, increase the dose by 30 to 50% every 2 to 3 days. So as we don't increase the frequency of morphine because the action lasts for 4 hours. So we can't increase the frequency. They can always take extra doses, but you have to increase the regular dose. So what happens? This patient is taking more than two extra doses. So we have to increase to 30 to 50%. So I can see a question. Dose should be increased as per patient's condition. I think I'll make a small correction there. I think we should increase the dose or dose correction should be done according to patient's pain score than the condition. I think that's what you meant also. The patient's pain, if it is more, and because the pain is more, that is why he's taking 4 doses, right? He's having increased pain in last 4 days. Maybe his disease is progressing. So we have to increase the dose to 30 to 50%. So he was on 5 milligram morphine, which I will increase to either 7.5 if you can break nicely, or you can give 10 milligram. It's slightly difficult to break morphine to 7.5, but people do that. That is okay. So you can increase to 7.5 milligram of morphine every 4 hours. Same thing you can do. Tell the patient to take extra dose, double dose at night, 15 milligram at night, and whenever they have pain, they should take extra 7.5 milligram. So how frequently you can give SOS dose? This patient told he has taken 4 doses. How frequently should we give? You can give as many doses, just that there has to be 1 hour interval between 2 doses. And if they are taking more rescue doses, you have to increase the dose. So have you anyone seen this plant? Highly unlikely you might have seen, because in India you can't grow this in your home. So this is called Papaver somniferum, from where the morphine is being extracted. Poppy plant, which is an opium poppy alkaloid. So it's like making latex. They make incisions or pour the pods. That round thing is a pod. They just pour, so the latex will come out. From that latex, they prepare morphine. Only there are 3 states in India which can legally produce morphine, which is MP, UP, and Rajasthan. Only 3 government approved factories. Yes, Gurpreet, yeah, you cannot grow it at home. There are specific areas under very correct under government observation. Otherwise, it's a big legal issue if you have yours being drawn. So this is how opioids are being made. So we'll see how morphine is absorbed, distributed, metabolized, and excreted, so that you will get an idea about the side effects and how it generally gives pain relief. We don't need to by heart all this. I'm just talking about, we'll just cover the practical aspect of it. It is absorbed in the upper small bowel. Why it is important? If you have any problem, if you have a gastrectomy done, or if you have some tumor in the upper GI, probably the absorption can be affected, right? Only that way you need to think. You don't need to by heart, okay, like in college days we learn it is absorbed in upper small bowel. No, we don't need that. Why it is relevant? Because if someone having some issues in the upper small bowel, we have to predict that pain relief might be little. We may need higher doses, probably the absorption can be affected. And the onset is slow, but it is longer. Longer means it will act for another 4 hours. It will take around 40 minutes to start having its peak pain relief action. So if you're giving oral morphine, tell them to wait for at least 40 minutes so that the morphine will start acting. Absorption, morphine cannot be given sublingual because it is not absorbed sublingually, buccally, or gingivally. So the absorption from the under the tongue or the gingiva is very low. So it is not usually given as sub. If you in your country you may have preparations which can be absorbed sublingually, but in our country we have only injectables and tablets, and some places have syrups in some regional cancer centers, but otherwise it is not, we don't have any sublingual forms available. So this is how it is done in a simple way. When they take morphine, it reaches the gastrointestinal tract where it is absorbed into the blood vessels, where it reaches the portal vein and then to the liver. Liver, it gets metabolized and absorbed into the systemic circulation like any other drug. This is very similar for any other drug that you take. Metabolism happens mainly in the liver, like most other drugs, and some metabolism happens in GIT. 90% metabolites are there. There are two metabolites. You just need to remember these two names, M3G and M6G. So majority is converted to M3G. A little bit, that is 5 to 10% is converted to M6G, morphine 6-gluconide, and that is exactly what we want. That 5 to 10% is M6G. M6G is the reason for pain relief. Okay. So again, we are reaching how frequently will you give SOS dose of morphine, which I told already. The absorption.
Hello.
Sister Priya, hello.
Hello.
Hello. Priya ma'am, please check your connectivity.
So, because it is its long duration of action is for 4 hours, you can give it 4th hourly, and so it takes only 40 minutes to reach its peak action. So you can give extra doses after 1 hour, just to be honest, 40 to 60 minutes. So we can give extra doses whenever the patient has pain after 1 hour of morphine dose. And this is another story. I hope you can just ask questions in the chat because this is a very, very important part. Mr. X's pain, now you increase the dose, right? 10 milligram 4th hourly. His pain is very, very stabilized. But he's telling it is very difficult to take every 4 hourly. I have to carry the medicines wherever I go. Every 4 hours, someone has to be there. So can you just make it less frequently? How can we do that? I don't want to take it every 4 hours. Sometimes some patients, they need someone to give the tablet. They don't know the time, or they don't know, they can't get up and take the medicine. Someone needs to be at home. Maybe the wife has to go for work. So there won't be anyone to give the tablet on time. So how will you manage this? How will you reduce the frequency? Is it possible? Is it okay to reduce? Because morphine acts only for 4 hours. How can we reduce the frequency? Just share whatever you feel like sharing. Yes, but even if we increase the dose, we have to give it 4th hourly, right? Because it lasts for only for 4 hours. So how will we manage? He doesn't want to take it 4th hourly. That is the problem. Change the duration. Yes, that's a very important point. That is one thing we can do. That is, we can change to sustained release morphine. Sustained release morphine, the duration of action is for 12 hours. There are many preparations available like sustained release, extended release. What we are using every 4th hourly is an immediate release, IR morphine, immediate release morphine. We have preparations called sustained release. the duration of action is 12 hours. So for this patient, he was taking, how much he was taking? 10 milligram fourth hourly means what was the total dose for him for a day? Anyone? 10 milligram fourth hourly. What was the total dose per day? No, that's simple mathematics. You don't need nursing skills for that. Aditi, we are giving fourth hourly. So how many doses in 24 hours? He's taking at 6 a.m., 10 a.m., 2 p.m., 6 p.m. and 10 p.m. Double dose at 10 p.m. Yeah. 60 milligram per day. So we have to divide it into PD dose. That is 12th hourly dose means 30 milligram SR. You just have to take morning 10 o'clock, 8 o'clock and night 8 o'clock. So we can convert it into sustained release. But one problem is there, you can give only this kind of conversion only for patients with stable pain, controlled pain relief. You can't give it for someone who has pain every now and then, right? If the pain is not in a controlled way, it is very, very fluctuating. Sustained release is not a good option. If the pain is very well controlled with 10 milligram or immediate release, you can always convert into sustained release preparation. So they have to take only twice a day. Okay. So what are the preparations of morphine available? These are, we do have tablets and injection, tablets, immediate release, sustained, or they say it's sustained release, controlled release, extended release. All of them have duration of action for around 12 hours. And some of the RCCs have aqueous solutions. They use it for children, or you can feed it through the NG tube, it's easier. So that is only some institutions in India have. Otherwise, it's always a tablet or the injectable forms available in the country. So we'll move on to the next story. So the same patient, he was on morphine for 10 milligram, 4th for last 6 months. Suddenly, one fine day, he is brought to your clinic telling that he is very, very sleepy, excessive drowsiness. And on examination, you found out that his creatinine was 5 milligram per deciliter. So what is happening? How can we manage this? Anything to be done with the morphine dose? He was okay for 6 months. Suddenly he became drowsy. What can be done? Anyone? Now we have heard that it is excreted through kidneys, right? We heard it is absorbed in or metabolized in liver, excreted through kidneys. So here the serum creatinine is 5. That means he may have a renal failure. So the morphine is not going out of the body. It is getting accumulated inside the body. So that is why he is having the toxic effect. Why? That is why he is drowsy. Yes, Evangeline, I totally agree. We can withhold morphine. That is one option. But how long? Because the patient is having pain also, right? He's having good pain relief, but then his kidneys are not excreting the morphine from the body, and it is getting accumulated inside the body. So he's getting drowsiness. That is a toxic effect of morphine. So one thing is that now we have heard that M6G accumulates in renal failure. As I told, it is not going out of the body. So clearance is decreased. So half-life is prolonged. Usually it will act only for 4 hours. Now the kidneys are not working. There is more morphine in the blood. It is not going out. So it will act for a longer period of time. So either you increase the spacing. So as you said, I will withhold the next dose. Next, because he is very drowsy. So next dose, I'll tell them not to give and increase the spacing. This person may not need what fourth hourly dose. We can either give it eighth hourly or according to the this renal clearance, you can decide. Either you can PID or BD, or as someone mentioned in the chat, you can use alternate opioids if you have alternate opioids. And we reduce the dose. So suppose he cannot afford fentanyl, okay, or we do not have fentanyl. I reduce the frequency to 5 milligram, 8 hourly. So only 3 times he has to take, which he is okay. There is no toxicity. But what happened? He had a cancer in the oropharyngeal region, right? After 2 months, he was unable to swallow anything. He stopped eating and drinking, including morphine. Now what will you do? He's at home, not in a hospital. I know that you will be right away thinking about intravenous. What will you do? Ice tube feeding, yeah, if yeah, subcutaneous. Shift to injection, yes. Fentanyl patch, yes. These are all correct responses. Many places they put in tubes to morphine patches. I'm not sure whether it is available. I have not seen morphine patches. I've seen only fentanyl and buprenorphine patches, not morphine. I don't think it is available here, at least. IV, yes, but then Aditi, he's in a home care setting, right? How will we give IV morphine? IV morphine is quite tricky because when we are giving titration, what did we do? We stopped when the patient was drowsy. How far the caregiver will understand if you give that, right? It's slightly tricky to give that, and most of the patients prefer to be at home, not in the hospital, because he knows the prognosis, right? We don't need the patient to be admitted just for pain relief. So many of the responses are correct. Yes, we need to change the route. Either you can change to subcutaneous or IV, tell them to come and get admitted, or give fentanyl patch if they can afford. So we'll see what are the routes for administration. As you mentioned correctly, IV or subcutaneous. Another route is oral. The third part is for rectal. So it is not a per rectal preparation, the same oral morphine tablet. If you're having a capsule preparation, this is not possible. If you're having tablet in your setting, you can just crush the tablet, mix it with a drop of water and apply it per rectally. It will start acting in 20 to 30 minutes. So this is one thing that you can, if the patient is in a community, in a rural place where they cannot bring the patient to hospital, they don't have access, or you can't give a morphine injection at home. This is one thing you can do, that is per rectal morphine. The same morphine can be crushed and give per rectally. Another route is epidural. Some places that patient has to come to the hospital, put an epidural catheter, and that's very tricky because these patients in many settings, they can't maintain this epidural catheter at home. This is again a hospital-based procedure. Intrathecal is another way where they can put intrathecal morphine pumps where it keep releasing morphine in a periodic way. And patient, now this particular patient, I'll give per rectal because he doesn't want to come to hospital. He was from a very rural place. He knew the prognosis and doesn't want to get admitted in a hospital. So we used per rectal morphine. So this is another story. Now the story of Mr. X, we have seen starting from his pain till he has gone through ups and downs, right? Now we see another lady with carcinoma colon with continuous abdominal pain on 10 milligram of morphine every 4th hourly. And she's okay. She did not need any extra dose. And one doctor told, okay, you put fentanyl patch now. Because anyway, the pain is very stable, right? Why do you want to take the tablet and have this constipation and stuff? Just put a patch. So he gave 25 microgram fentanyl patch. Next day, the patient is coming to you telling that I removed the patch after 5 hours because there was no pain relief. Put the patch, I waited for 5 hours, there was no pain relief, I just removed the patch. What will you do? People who are using fentanyl patch, who are using fentanyl patch, this might be something that you will know. What can be done? What will you tell the patient when you apply a patch or fentanyl patch? Very correct, Gurpreet. Advise the patient to continue with morphine. Why? Why do you want to continue? You already gave fentanyl. The answer, the response was very correct. The transdermal patch, once you put a transdermal fentanyl patch, it will form a subcutaneous depot. There is another depot of drug which is formed subcutaneous, like a small reservoir. Wherever you put the patch, there is a subcutaneous reservoir which is formed. And from that, the drug needs to be released into the blood, which will take another 8 to 12 hours. So even if you put a patch now, it will start acting only after 8 to 12 hours. So literally you are out of analgesia if you just put a patch and send the patient back. And the effect lasts for 72 hours. And sometimes if you are in a very humid climate like in Kerala where you sweat a lot, this skin condition and temperature can affect the absorption. And it is not suitable for patients with unstable pain. So this lady had a stable pain. What happened? Whenever you put a fentanyl patch, you have to tell the patient that this will start acting only after 8 to 12 hours. So as Gurpreet mentioned in the chat, you have to continue morphine. Tell them till 12 hours. So now I put the patch at 4 o'clock now. Till tomorrow morning, you have to continue morphine and then stop. Okay, because it forms a subcutaneous reservoir and from there the release happens. It will take time. You just don't put the patch and send the patient back. The patient will end up in having severe pain. Continue morphine. And what are the preparations available? Injection, that is what is available here. Transdermal patches, oral transmucosal fentanyl citrate, OTFC. And sometimes some places they get fentanyl lollipops, which is absorbed in transmucosally. It is 100 to 150 times more potent than morphine. Conversion also. If someone is taking 60 milligram of morphine per day, you have to apply 25 microgram patch. 25 microgram per hour. You see the patch, you can see that 25 microgram per hour or 50 microgram per hour. Next, we'll see how will you choose opioid. There are so many opioids, right? Fentanyl, morphine, injection, oral, everything. So this is a 70-year-old man who has carcinoma of lung and he has severe throbbing pain on front of the chest. He's telling it is 5 out of 10. But he has a history of epilepsy and he's taking anti-epileptic phenytoin. So the pain is moderate. Which drug in the WHO ladder will you choose for moderate pain? 5. Which drug can be given to this patient? Ideally, patients with moderate pain, we start with tramadol. But there is a catch here because the patient is having what history of seizures and he is on anti-epileptic and this patient, there is a potential for decreasing the seizure threshold. I don't know whether you have heard during the last session, tramadol decreases the seizure threshold. So in patients with the potential to have seizures, If you give injection tramadol or tablet tramadol, there is a high chance that patients will have seizures. So you have to be very, very careful. You can either use a low dose morphine or you have to inform. It is not very commonly seen, but it is highly possible that patient will end up having seizures. So you have to be very careful when you choose tramadol. But score, yes. For moderate pain, you have to give tramadol, but you have to be careful. This is another patient with 50 milligram morphine every 4 hours. She's coming to your clinic with severe pain. You have injection pentazocine and oral morphine tablet. Which one will you give? You don't have injection morphine. Pentazocine is very commonly used, right? For twin. Which class of drug is pentazocine? Or you have these two options. I'll just say there are certain terms that we use when we talk about opioids, which is naturally occurring, semi-synthetic, synthetic, and just we'll see a little bit of pharmacology so that you will understand why I want to give pentazocine or morphine. There are different receptors for opioids. Mu, kappa, and delta are the important ones. Sigma is not really documented, but mu, kappa, and delta are the significant receptors of opioid. And where all it is, and what all kind of receptors are there, you might have learned this in pharmacology, agonist, antagonist, and combination of agonist, antagonist. Okay, I'm not confusing you a lot with this, but just to understand that when you are giving an agonist, the more the pain, you can keep increasing the dose. But in case of mixed antagonist or partial agonist, you cannot increase the dose after a particular limit. For example, you can't go beyond 400 milligram of tramadol. There is a ceiling, right? Beyond which, if you give, there is no analgesic effect. It cannot be used as an analgesic. You can't give more than 800 milligram of or 1200 milligram of brufen. You can't go beyond that. The analgesic activity will be stopping after that. But for a pure agonist, for pain management, the more the pain, you can increase the dose. I'll just come to that point. Now we heard about the pentazocine. Pentazocine is a combination, that is a agonist antagonist. So there is a ceiling effect. You can't go beyond a particular dose. But whereas morphine is a pure agonist. So when you give, so this patient was already on oral morphine, right? The patient is coming to your clinic with severe pain. If you give pentazocine, what happens is that the pentazocine will replace morphine from the mu receptor. So morphine's action will be reduced. So you cannot, it's better to avoid giving pentazocine or buprenorphine or any partial or mixed agonist, antagonist when the patient is on strong opioids. I'll come to that concept again. So essentially this graph means that you can increase the morphine dose according to patient's pain. There is no ceiling effect for analgesic effect of morphine. There are patients who get good pain relief with 5 milligram of morphine. There are patients who are on 100 milligram of morphine every 4th hour. They go up to 50 to 100 milligram every 4th hour. So morphine does not, or strong opioid, morphine, fentanyl, and methadone, they do not have a ceiling effect on analgesia. The more the pain, the more dose you can give. There is no ceiling effect. If you give pentazocine or buprenorphine or tramadol, you have a ceiling. You hit the ceiling when you go up, right? You have to stop there. There is no pain effect after that. So when the patient is coming to your clinic, you have injection morphine, injection pentazocine and morphine, ask whether they have missed any dose of morphine, first thing. And it is better to use your tablet morphine. Otherwise, what happens if you give pentazocine, it will replace morphine from the new receptors. What are the side effects? So there are two things that you need to remember: side effects and the toxic effects. Side effects are constipation, nausea, vomiting, sleepiness, that is drowsiness, and itching. And you know that in any anticholinergic effect like dry mouth, urinary hesitancy, morphine has all its anticholinergic effect. The most important one is constipation because it is very commonly seen in 95% of the patients will have constipation. You have to give regular laxative. They don't get used to constipation. As far as they are taking morphine, they'll be constipated. 95% of them. So we have to give regular laxatives. Nausea and vomiting is seen in 1/3 of the patient. It is generally self-limiting. Initial 3 to 4 days, they will have nausea and vomiting, and after that, it is reversible. So you need to give antiemetic only for initial 3 to 5 days. After that, you can stop the antiemetic. But laxatives, you need to continue laxatives as long as the patient is on morphine. And next is sleepiness and tiredness. Initial 1 to 3 to 5 days, the patients, some of them will say that I am feeling more sleepy, but generally it is self-limiting. It disappears after 3 to 5 days, but constipation will not disappear. So we saw the side effects. Side effects are constipation, nausea, vomiting, and sleepiness, dry mouth, itching, etc. Next comes the toxic effect. There is a difference between side effect and toxic effect. What is the difference? It is the adverse effect that happens when you're giving higher doses than needed. I may not need 50 milligram, but you have given 60 milligram. Then I'll have toxic effects. The toxic effects are delirium, myoclonus, and undue drowsiness, severe drowsiness, not just feeling sleepy. He's not getting up to have meals, not talking because of sleepiness. 3 things you have to remember and tell the patient whenever you start morphine, that report to you when they have irrelevant talk or delirious activity, myoclonus like jerky movements of hands and legs, or undue drowsiness. So toxic effects and side effects. Side effects can happen with any dose. Toxic effect will happen only if you give more than needed dose. Will opioids produce respiratory depression? Any experience? I understand there are a few people who knows or uses morphine. Yes. So how will we treat all this cancer pain if the opioids are going to cause respiratory depression, right? Is it a really concerning thing? So opioids, if they are patients take their medications by the mouth, if they are taking orally, combined with gradual increase in dose, it ensures that respiratory depression is unusual. If you are given titrated dose, as we mentioned, IV titration, oral titration, how to increase 50%, etc., everything you learn. If you go by this approach, and if the patient is taking orally, there is very, very less. I have not seen other than the patient is trying to take 10-20 tablets together to attempt suicide, probably they may end up in respiratory depression. Otherwise, I have not seen in last 10 years, not even a single patient dying of respiratory depression. That is for oral morphine, because you know what, you take a morphine, if you are giving extra dose or toxic dose, the patient will start becoming drowsy or delirious. They won't take more doses. Intravenous is different because you can keep injecting drug. But morphine, oral morphine, the patient has to be conscious to take the next dose. The moment they are reaching above the threshold, they'll start feeling sleepy. So they can't take any more doses. So with oral morphine, there is a very less chance to have respiratory depression. It is very commonly seen that people will tell you, can morphine cause addiction? So this is a research finding. Substance abuse as a result of medical use is low. If you are providing morphine for pain relief, there is no chance for having addiction. You have to understand the difference between physical dependence and addiction. Both are different. When the patient is having inadequate pain control and taking extra doses, you can't tell that the patient is addicted to morphine. He's having pain. He's having a cancer. That is why he is asking for more doses. It is not addiction. So, what is addiction? It is a genetic disorder. It is a psychological dependence where, irrespective of their diagnosis or their pain, they keep taking unsanctioned doses. They don't have control over the drug. They use compulsive doses and they take unsanctioned doses. They may tell you, I lost one packet of morphine somewhere every time, not even once. Or someone has taken away one packet of morphine. These are the things that you need to be careful. In cancer pain, it is very, very unlikely that patients will end up in having addiction. Physical dependence is possible when you stop morphine suddenly. In same as that of steroid, we tell no, the steroid cannot be stopped abruptly. If they are taking for a longer period of time, it can cause suppression of adrenal axis. So same way, if you stop morphine suddenly, it can cause withdrawal syndrome. You have to taper the dose and then stop morphine. You can't just stop suddenly. So another prescription, Mr. X have severe pain and you are starting him on morphine. How will you write the prescription? This will be the normal prescription. You have to write the morphine, what preparation, oral, the time, the extra dose, how many numbers you have given, plus a laxative, plus an antiemetic for 3 days. This is the typical morphine prescription that we issue. And you have to make sure that you have to nurses can't prescribe, I understand, but just for your knowledge that you have, the doctor has to put their name, signature, medical council registration number and the institution address. This is the typical morphine prescription. This patient was on tramadol 50 milligram 8 hourly. Now she has severe pain and we are starting with morphine 5 milligram Q4H. And this is the prescription, tramadol, and you give morphine and liquid paraffin. Anything wrong in this prescription? As we are going to exceed time, I'll just run through the answer. You should not, first thing, the patient's name, age, gender, everything should be there. Generally, we should not combine step 2 or weak and strong opioid together. We heard agonist, antagonist, how it is going to affect morphine's action. So you should not ideally combine a weak and a strong opioid. Tramadol is a weak opioid. Morphine is a strong opioid. You should not combine it. Liquid paraffin is not the laxative of choice. That we will have another session on that. So this is the cost per day. Morphine is very, very cheap. If you are starting with 5 milligram 4th hourly, it will cost only 3 rupees for the patient. But if you are writing tramadol 300 milligram per day, that is going to cost around 24 to 50 rupees per day. And look at the rate of fentanyl patch. 250 to 400 rupees for one patch. Some patches, Duragetic company patches cost around 600 or so. This is the average rate. And there is another drug which we have not mentioned yet, that is methadone. Methadone is another cheaper drug, 5 milligram methadone cost only 4 rupees. So this is what we need to think when you prescribe patches or tramadol to patients. So I'll just take up a few questions before the case presentation. Is it would you ever check a patient's liver function? Liana, no, we don't do that. If the patient is having a deranged liver function, maybe we can reduce the frequency of morphine, but we don't check the liver function because we can't correlate in a way that if the liver function is between this and this, then the morphine dose should be this. So the morphine dose is always decided by the pain score. So we ask for the pain score. Even in liver failure or renal failure, we use opioids, but the frequency can be increased. The interval can be increased. You can adjust the dose to 8 hourly. depending on the absorption, and you can always monitor. Even patients with dialysis or acute renal failure, chronic renal failure, most of them are on morphine. We just have to decrease the frequency of the dose.
Any other questions?
Very important topic. You need to understand how to give morphine, what all to tell the patient when you give morphine. That you just suppose you are just giving a prescription of morphine with a laxative. Will the patient take the laxative? I will think to that, oh, I think the doctor made a mistake. I do not have constipation. Why should I take a laxative? I'll end up in a loose stools. I don't want to do that. So I'll not take. So you have the duty to tell them that this medicine, morphine, can cause severe constipation. That is going to create more problem. 95%, 95 to 97% of patients will have constipation. So you have to tell them that you have to, even if you don't have any problem right now, you have to take the laxative. Same thing with the antiemetic. If you just don't tell them why you are giving metoclopramide and just give, they'll feel, hey, I don't have vomiting, I don't have nausea and vomiting, why should I take this tablet? So you have to tell, you may have nausea for initial 3 to 4 days, so take this medication. So that is why it is very important for you all to know why this is given, how this is being given. You have to tell the same to the patient and the family.
If there is no question, we can move on to the case presentation part. Is it okay?
Yes, we can.
Liana?
Hello.
Yeah, yes. Okay.
As you have requested, you can keep your video off while doing the presentation. I'm going to request to turn my video off just to make sure network stays okay. But I hope you can hear me. Hi, my name is Liana. I'm a registered nurse and a director of a nonprofit organization here in southwestern Uganda. I will be presenting on one of our patients enrolled into our NGO. We provide home-based palliative care and outpatient services. So she is a 62-year-old female diagnosed with breast cancer. So she is one of our patients who receives palliative care from home. In April, when she was first enrolled into our program, she was complaining of right breast pain, 4 out of 5. Often in Uganda, we use the hand to assess pain. So you will see that's why it's out of 5. If you want the NRS, you can just double it. She was also complaining of lower back pain, 2 out of 5. So that wasn't too severe. Complaining of constipation, dizziness, insomnia, and stress related to one of her grandchild's school fees and ailing illness. Our social worker on our team met with her and got to know her history. And so according to this patient, she received a tetanus booster shot in 2011 that led to some complications, including arm pain and swelling, which she had for 5 years. She was then diagnosed with breast cancer from the local regional referral hospital, that is the government-run hospital, in 2016. She has no known comorbidities. However, currently our team is ruling out hypertension. There are no known comorbidities in her family. She does have a history of depression and insomnia. For her surgical history, she told us that she had a lumpectomy from her right shoulder in 2011. We think it has to do with the shot that she was given. And then she also had a lumpectomy from her right breast in 2016. So early April of this year, one of our team members found her in town and she was selling baskets to earn some income. And so after selling a basket, she then showed us a picture of her right breast. And so we saw that it was cancer and asked her to come to our office to be enrolled in our palliative care program. So she was enrolled on April 13, 2022. When she was enrolled, this was her physical exam and vitals. Her weight is 55 kilos. She's 160 centimeters tall. I don't know if you check this in India, but we like to check the MWAC. It's the mid upper arm circumference, which was 23. So it's normal. She's in the green range. I hope you can hear me. Everyone is frozen, but are you there?
We can hear you.
Okay, thank you. Her BP has been running quite high. You can see it's 175/95. That is why we are monitoring if she has hypertension. We were explaining other ways to reduce it. And if it doesn't reduce soon, she will be placed on antihypertensives. Her heart rate's normal, respiration's 22, unknown SpO2, but she doesn't appear to have shortness of breath. She has been afebrile. For her general exam, her skin is warm to touch, dry, turgor is poor. It could be because of her age or dehydration. There is no edema. Her heart is fine, maybe hypertension, as I mentioned. Pulse is regular, S1 and S2 heard. Respiratory is fine. There are no complications there. Abdomen was distended, probably due to constipation at the time, but thankfully that has gone away. Bowel sounds heard times 4 quadrants. She is alert and oriented. Her memory is there. She knows where she is, what's happening with her diagnosis. She doesn't have any mobility problems, no assisted devices, full range of motion, which is good, so she can still take care of herself at home. For her pain assessment, there's moderate to severe pain in breast and back. That is when she is not on morphine, which I will discuss soon. So where we are in southwestern Uganda, many people can't afford chemotherapy or treatment. There is chemo and radiation in Uganda, but it is quite far from where we are. It takes about 6 to 7 hours just to reach that hospital. And so for her, she hasn't gone any of those interventions. However, just recently in June, she was operated under general anesthesia to examine her rectum and vagina to rule out complaints of bleeding. And so there was a noted mass in rectum, no biopsy performed due to cost. So at the end, I'll be asking you a question about that treatment. So she was widowed. She has 6 children, but 2 of them passed away. She lives 20 kilometers from town, which is quite far. So one of her biggest concerns when we met her is that when her morphine and medications ran out, she had difficulty accessing town if she didn't have money. She would have to walk that long distance, and imagine walking 20 kilometers when you're in severe pain. So that was something causing her a lot of distress. She owns a temporary house on owned land, although it's small for her, but at least she doesn't have to pay rent anywhere. She makes beautiful hand-woven baskets, but because she's vulnerable, people don't purchase at a fair price, which is unfortunate. And so what we do as an organization, we purchase them at a fair price, and then we help her sell them as one source of income for her. Currently, our social worker is creating a will for her, both a living and a dying will. Hopefully that will give her more peace. She is a Christian and she attends church regularly near her home. So currently she is on liquid oral morphine. And in Uganda, liquid oral morphine is free for everyone, which is great. That's from Hospice Africa, Uganda. And so she doesn't have to pay for any of those medications. She's on 5 milligrams 4 times a day, and she's been on that since 2016. She's also on a laxative, and it manages her pain. However, when she runs out, that's when the pain spikes. So our team really tries to make sure we know when her morphine is running out so that we can give her a refill. Her past medications include Metro, amoxicillin, and amitriptyline. Amitriptyline because she was suffering with insomnia. Thank you. So our main concerns, we need to continue to manage her pain. As I just mentioned, we want to prevent and manage constipation, which hasn't been a complaint, which is good. We will continue to offer counseling and occasional medications to support her insomnia. But our social worker identified that the insomnia comes to anxiety due to her grandchild that she's taking care of. She has to find school fees for her. She's going to complete a living and dying will, and then we'll continue to address her anxiety related to imminent death. As it does appear, her cancer has metastasized according to the mass found in her rectum. Although she isn't aware of that, I'm going to lead to that question soon. So she is dependent on selling these baskets, which is why we're trying to support her in that so she can receive more income. So in summary, this is a 62-year-old female with possible stage 4 cancer receiving home-based palliative care. Pain and other side effects are currently managed, so we're thankful for that. She will continue to receive ongoing counseling and active preparation for next stage in life regarding her illness. So I wanted to ask you 2 questions, and I'm really curious to hear your response. So I mentioned she recently had surgery because she had some rectal bleeding. So would you recommend the patient to undergo biopsy from the rectal mass, even though she can't afford it? Why or why not? Okay, thank you. There's one more question, but I'm done.
Thank you, Liana, for the excellent presentation. Anybody need or any clarification needed, please ask that. Otherwise, we can move on to discussion points. So I hope the presentation is clear to everyone. So we can move to the discussion points. So we would like to hear from the participant side first. Ma'am.
What do you all think? Should we go for the biopsy from the rectal mass, considering the situation that she's working, Liana is working? We can discuss both. What if the patient is in our country? Will you recommend going for a biopsy, and what there? Will you tell Lian that you didn't send the patient
Yeah,
for?
firstly, sorry to interrupt you. Firstly, we just advise the patient that they need the diagnostic evaluation as well. But according to some of the patients, they just have financial constraints and they do not perform it. So actually, if they perform it, but they do not have money for their further treatment, so according to the budget system, we just guide them, and it is the totally patient choice, and we just have to follow it.
Thank you, Gurpreet, for telling your suggestion. Like sometimes there will be a lot of financial constraints, so they may not even want, because what if it is advanced cancer? Where will I go for treatment? Anyway, I don't have money. So, so what do others think about it? There can be difference of opinion. There are some people who feel that you have to undergo treatment if it is curable. So I'd like to hear from others also. And should we tell about the diagnosis to her? She seems pretty settled and peaceful, because there is a team going regularly and maybe good pain relief is she's getting. So, I mean, yeah, we have an intense session on this particular head that should we discuss the diagnosis. But still, what do you all think about the biopsy part and the diagnosis?
Like in some of the hospital settings, patients, some of the doctors, they do not disclose the diagnosis with the patient because actually it totally affect the patient's psychology as well. So it is a better thing if patient do not know about his disease condition. And one of my case in my non, actually, they are just suffering from CS cervix, but the family member, they do not disclose that condition with that family member. and she is fine out now, and she just even thinks so that it is just normal infection or something else. So right now she's very good, and right now she is very healthy. So it is a better thing. Do not disclose the disease condition of the patient with patient. So according to my point of view, it is a very good thing. So never disclose the disease condition of the patient, because they just have some psychological problems like stress and other anxiety disorders. So which will help to leave the disease the precipitate. So disease will enhance more. So it is a better thing. Do not disclose.
So I think Sister Kanjan is telling that she has to be explained about her condition. So I totally agree. Like both are right answers. Some situations we need to tell the patient what is going to happen. You have a very detailed 2 sessions on communication, when to tell, what to tell, whether to tell or not, and what are the benefits or the risks of telling. I'm not going into details, but I agree that there are situations where we cannot tell or we may not be able to tell at all. Or sometimes there are situations that where we have to pursue, that it becomes so important that they know about their diagnosis for many, many aspects coming in the future. So I think that's something that we'll discuss in the session. I personally feel that the same thing that you were mentioning. It seems very difficult to undergo biopsy, and then if there is something to, because even with her earlier diagnosis, she was unable to get chemotherapy due to the financial constraints. So what difference will it make to the patient's quality of life if you are pursuing for biopsy? If you are doing it, then it comes positive. You have to give options for treatment. If they are unable to do it at all, it becomes sometimes we give lot of guilt that I have a disease, but I am unable to treat because I don't have money. If I had money, I would have got good treatment and I would have lived some more time. So essentially, you will be giving a little bit of guilt that because you are poor, you are going to die of cancer because you can't afford treatment. Yes, Sister Sunita, it is very true. Many of the in India, if we take in India, the cancer centers or the government institutions, many of the treatment are given for free, or at least in some insurance schemes cover many of this treatment in even in a private sector. Government insurance schemes like Ayushman Bharat, but people are not aware. Even in Kerala, many of the treatment like radiotherapy, chemotherapy, up to an extent is being covered under government schemes if they are financially backward. That is there. But then there is another problem, like even if the treatment is free, it costs a lot for someone to come from home to that particular center. We see that on a daily basis. That for radiation, they generally don't admit the patient. They have to come consequently for 21 days for radiation, for example. They have to travel up and down. There are some NGOs who give free food and accommodation, then that is fine. But otherwise, traveling up and down for travel will cost them around 1,000 rupees to get a rickshaw or an ambulance, which is very expensive. Sometimes, so they decide that even if the treatment is free, they may not be able to go for the treatment because of the hidden charges. Someone has to take leave from work. Someone has to go along with the patient. All these all these things are a problem here in our place. Yeah, so Kanjan is telling people are taking advantage of these kind of schemes. I don't know. I'm not sure. Sometimes, yeah, these kind of schemes. But I think here they ask for all this documentation from the doctors, whether they are taking, whether they are, what kind of treatment they are taking and the cost and everything. But highly possible that this may be happening in some places. But sometimes, not just for this patient has a rectal mass, but sometimes uh, there is already a badly progressing cancer already, and you are suspecting something else. If the patient is clearly on a disease, low end of the disease trajectory, then we may not want to go for further investigation. So the question is, what help, what advantage the patient is going to get out of this? That is the only thing that we have to think. If I suggest this particular test, if I suggest this particular treatment, is the patient's quality of life is going to be improved? What if it is a stage 1 rectal cancer, which is completely curable? Is the patient's quality of life is going to be better? She may live longer, she may make more baskets, she may be able to take care of the grandchild for a longer period of time. So we don't know. So if it is a more disease, curable early stage cancer, probably even after a lot of difficulties, if they can get a good quality of life, probably we may think of it. But if it is a very progressive patient, already has one cancer for which the patient has not undergone treatment and they cannot afford also, then I may think whether how far this is going to help the patient and the family. Is it going to create more help, or are you actually going to harm them? That is one thing that we need to consider. Liana, I don't have a clear-cut answer of yes, she needs a biopsy, or no, she doesn't need a biopsy. These are all things that dilemmas that we all go through on a daily basis in every setting. That is it okay to tell, not to tell that biopsies, that we are not recommending biopsy, but looking at her situations, I think that is going to overburden the patient than going to be helpful. And the second part of the question will definitely be covered in a wonderful way in the coming sessions on communication. So I'm not going into details, but it varies from patient to patient. Any other comments? Anyone else?
Shiva ma'am, do you
Yeah.
have?
So, thank you, Dr. Sreedevi, for the update. I am totally agree with you. So, before wind up the session, I'd like to highlight few things. This is one of the very, very important session, especially on morphine, about morphine and strong opioids. The caregiver and the patient education is very, very important. So whenever the doctor prescribed morphine, the caregiver doesn't know, the patient doesn't know how to take it, what are the action, the duration of action, that is, they doesn't know. So we need to educate them, instruct them properly, so that otherwise they won't take clearly, they won't take it properly. So that is very, very important. So always try to communicate with them in that local language to avoid medical jargon. And also we understand that morphine has 3 to 4 hours action, so they need to take every 4 hourly, and the night dose they should be take double dose. So otherwise in between they will maybe the pain arise in between, so they need to wake up during the sleep time also. So they need to take the night dose at a double dose. And the importance of rescue dose also you have to tell them, because the same dose, they if in between they will have a pain, so they have a pain, they will take a same dose as a rescue dose. That is also you have to tell them. And also the one of the most important side effect as Dr. Sreedevi said earlier, constipation, that is one of the most common side effects. They should take laxatives, that not a laxative, stimulant laxatives at night, so that you have to monitor properly whether their bowel movement is regularly happening or not. That is also very, very important. And another thing is the first few days, nausea, vomiting, tiredness, these will be there. So that is self-limiting. For nausea, vomiting, they should take metoclopramide for 3 to 5 days. So after that, they will be used to. So, and the another thing is toxic effect. Regarding the toxic effect, also you have to tell the caregivers and the patient, drowsiness, delirium, myoclonus. So these are the most common to the toxic effect. If they have these kind of things, they need to report us. And so the another important things is you have to convey with them is morphine should be specific to the prescribed patient. It should not be used by any other person. So it is for their pain. That important things you have to tell the patient. This is very, very important. And also if they take a rescue dose in between, they should not miss the regular dose. They need to continue the rescue dose, but if they take the rescue dose, they have to note it down and report us. So if they take more than 3 to 5 doses in a day, we need to increase the dose of the morphine. So that is that these are the important points. You have to keep it in mind. You have to tell the caregivers and the patient when we start morphine. So these are the points you can tell them. And regarding the case presentation, as ma'am said, for the biopsy thing, only the financial problem is there. You can find some financial support, but after that, if the patient is not doing anything after biopsy, there is no point. So that is very, very important. So if we are able to improve the quality of life, we can do something for that patient. And the next thing is that for the diagnosis part, I would say if she wants to know the diagnosis, definitely we should say the diagnosis, but we should know how to tell the diagnosis. So we have a session on communication, part 1 and part 2. So that time we will learn more about that thing. Okay, thank you. We can wind up the session. Thank you, Dr. Sreedevi, for the excellent presentation. It was very clear, it's understandable, and I hope everyone the presentation was clear to everyone. Thank you, Liana, for the wonderful case presentation. We also learned something from your case presentation. Thank you once again. Thank you.
Thank you all for joining us today. Kindly fill in the feedback form that we have shared with you, that have been shared to your WhatsApp group also. We'll see you on the next class on communication. Bye until then.